last lesson, the most important thing to remember is going to be about the gut tube. Okay, so about the endodermal gut tube. So gut tube, right? So this is a very important part of the embryo because it is responsible for the entire GI. So all of the gastrointestinal tract is going to arise from this gut tube. And not only, also a part of the respiratory system will come from there, also a part of the urinary system will come from there, and even a little bit of the genital system will come from here as well. So this formation of the gut tube, we discussed this last lesson. Could you tell me what are the two foldings that are responsible for the gut tube formation? How do we call those foldings? We talked about them yesterday.
Cephalocaudal?
Cephalocaudal, don't forget the keyword flexion, okay?
Flexion.
Cephalocaudal flexion is a very important one, right? So when the head of the embryo and the tail, they kind of come closer together, right? So this is the head, this is the tail, and they come closer like this. This is the cephalocaudal flexion. And how do you call the flexion that is like this?
Lateral flexion.
Yeah, so this is going to be not flexion, sorry, this is the lateral folding, right? So cephalocaudal flexion and lateral folding are responsible for making your embryo, which was a disc, right? So it is making it to become a cylinder. Take a look at your trunk right now. This is a cylinder-like structure, right? So this was the part that we have discussed this yesterday. What are the three parts of the gut tube? How do we call the three parts of the gut tube?
Foregut, midgut, hindgut.
Very good. So there's one which is known as the foregut, there is one which is the midgut, and there is the hindgut. Of course, the foregut is going to be opening up into the primitive oral cavity. The primitive oral cavity in the Latin language, this is also known as the stoma deum. Okay, so it is written as stoma, and then in Latin deum is the cavity. So foregut, the endodermal cephalic gut tube, it's going to be opening up into the primitive oral cavity, which we're going to call stoma deum. There's also the hindgut, right, which is on the opposite end, and hindgut is going to be opening up into the primitive anal cavity. And primitive anal cavity is known as the proctodeum. Because think about it, the doctor that deals with the hemorrhoids, right? So some kind of anal problems, that doctor is known as the proctologist. So proctodeum is the primitive anal cavity. Could you tell me which germ layer is going to be lining these cavities?
Ectoderm.
Ectoderm. And why is it going to be ectoderm? Why not endoderm? Why not mesoderm? Why ectoderm specifically?
Is that because it's the skin?
Because it is facing outside, yes. So partially you're correct, because it is the skin, but also because it is facing outside. And last class, I asked you to look at what does ectoderm gives rise to, and you should remember that it gives rise to any structure that helps you to communicate with the outside world. And your anal cavity, a part of it, right? So it's literally facing the outside world. That's where it is going to be lined by the skin. Oral cavity is not going to be lined by the skin, right? The inner part of your oral cavity is not skin, but it is facing the external environment, so it is going to be the ectoderm. What is this little tiny thing here where we have the midgut? What is it connected to?
Secondary yolk sac.
So it's connected to the yolk sac. You can just say yolk sac. Just remember that it is secondary because from day 14, right? So this is when it becomes secondary. And how do we call this thing that connects? vitelline duct. Okay, so this little connection between the midgut and the yolk sac, this is known as the vitelline duct. Now, you should remember what is the pharyngeal gut tube. In a way, you can think about it this way, that extension, so extension of the foregut, this is known as the pharyngeal gut tube. If I have to show on myself, where does the foregut finishes, right? So where is the place where it finishes? You would say somewhere in the neck region, so somewhere here. This is where the foregut stops. Everything else up until your eyes, this is going to be the pharyngeal gut tube. So to show pharyngeal gut tube on yourself, it's somewhere at the bottom of your neck until your eyes. So this entire region right here, so half of your face and pretty much the entire neck, this is the pharyngeal gut tube. You must remember that embryo or even fetus does not have a neck. They don't have a neck, okay? So the head kind of comes out from the body directly. The neck appears after birth, okay? So slowly it starts to elongate after birth. So this is why whenever you think about the pharyngeal gut tube, think about it in a very weird position, that it is not like you, right? So elongated neck and normal half of the face. In embryo, it will look something like this, okay? That it's very much close up to the body itself. Okay, so this entire region will be very close to the trunk itself. The pharyngeal gut tube consists of pharyngeal arches, right? So if we have to kind of show it, how does the pharyngeal gut tube look like? It looks like a bunch of pharyngeal arches. And if you take a look at these pharyngeal arches, they look like gills. You know, fishes, they have gills through which they are able to breathe underwater, right? So these pharyngeal arches of the pharyngeal gut tube, they look like gills. Some professors call these pharyngeal arches as branchial arches. Why? Because branchia is another name for gills. So I repeat, gills are the fishes, they have it in their neck region to breathe underwater. It looks like gills, right? It looks like gills. So older professors call these pharyngeal arches as branchial arches because branchia is the same as gills. Do pharyngeal arches have the same function as gills? Of course not, okay? So it's a completely different structure, but still, for some reason, they call them branchial arches. A proper modern name for this part right here, this is going to be known as the pharyngeal arches. So I repeat, this is your pharyngeal gut, right? So this region right here, including your neck, this is the pharyngeal gut. What does pharyngeal gut consist of? It consists of the pharyngeal arches. Now, we have to look at the face of the embryo. So this is straight up face. You're looking straight into the face of the embryo. So this embryo is approximately 24 days old. And this embryo is approximately 48 days old. Okay, so 24, 48. What are some of the changes? Immediately, the first thing that you must notice is the stomadeum. Stomadeum is the little opening in the center of the face of the embryo. Stomadeum is a very primitive oral cavity. Okay, so this is where the tongue will be formed at the later stages. This is where the teeth will be formed at the later stages. So this is a very primitive oral opening. You can't even probably say cavity. Opening will be a bit better. Primitive oral opening. This primitive oral opening is going to be lined by the ectoderm, right? Why ectoderm? Because it is facing the outside world. Stomadeum, as we can see on day 24, is surrounded by some kind of prominences. Prominences are just protrusions, right? So they're literally little swellings, facial swellings that we have. The biggest one is known as the frontonasal prominence. And if I have to show it on myself, It starts from your eyes region, right? So from here, and it goes all the way to the back, okay? So all the way here. So imagine that there is a huge swelling right here, a huge prominence in this region, and this is known as the frontonasal prominence. To talk about frontonasal prominence, I wrote it somewhere else, but please add it here. What does it consist of, right? So what is inside of this frontonasal prominence? Mesenchyme. So its core is going to be mesenchyme. You must remember that certain cells absolutely love mesenchyme. They love to accumulate there. And these cells are neural crest cells. So frontonasal prominence's core, right, the inside of it is going to be filled with mesenchyme and neural crest cells. What about on the surface of the frontonasal prominence, right? So its most outer layer, what is it going to be? Of course, ectoderm, because it is facing outside. It's the most outer part. It's the one which will become skin. Do not forget that whenever you say that ectoderm will become skin, remember that skin has 3 layers. So to be more specific, which layer of the skin ectoderm will become? What are the layers of the skin?
What do you mean, like the top layer or first layer?
Yeah, so how do we call this top layer of the skin?
Epidermis.
Epidermis. Okay, so whenever you're saying that ectoderm will become skin, just remember not the entire skin. Yeah, so specifically the epidermis only. Dermis and hypodermis will come from somewhere else. Okay, so they are going to arise from somewhere else. So frontonasal prominence understood, right? So this is a huge prominence that we have somewhere here. Your eyes will be developing on the frontonasal prominence as well, together with your nose as well. Okay, so actually pretty much all of your sensory parts are going to be developing there. So ears, eyes, and nose, they will be developing at first on the surface of the frontonasal prominence. Now, on the 2 sides of the stomadeum, we can see the maxillary prominences, right? So we can see them here. So these are the maxillary prominences, and we can see mandibular prominences. And I really want you to see that there are 2 mandibular prominences. And at the later stage, by day 48, they should fuse. They should fuse in the middle right here. So at first you started with the 2 mandibular prominences, but by the day 48, they will fuse into 1. Why am I showing you the face of the embryo? Because together, maxillary and mandibular prominence together, they correspond to the first pharyngeal arch. So we said that an entire pharyngeal gut tube consists of pharyngeal arches. Where is the first pharyngeal arch? It's right here. It's your half of your face. So maxillary and mandibular prominences together, they are making up the first pharyngeal arch. So half of your face is the first pharyngeal arch. How many pharyngeal arches do we actually have? A very good picture is this one. Sometimes they ask you to draw it to understand how you actually kind of made it. Okay, this drawing, a picture is here. So you can see that this part right here, this is your frontonasal prominence. By the way, which kind of structure do you think will be growing behind frontonasal prominence? We said that this is your frontonasal prominence. What will be growing behind it?
Brain.
Brain. The brain is going to be developing behind it. So this is why sometimes they ask you this question. They ask, what is the purpose of the frontonasal prominence in the early development stages? In the early development stages, frontonasal prominence is responsible for protecting the developing brain. It's very it's very cushiony, right? It's like providing this pillow-like protection of the brain until the skull will develop at the later stages, because take a look, this is still very early, right? So this is still day 24. There is no skull, there is no bone there, but we still need to protect the developing brain somehow. So this is where the frontonasal prominence comes in. All of this mesenchyme is going to be surrounding the brain, and as a result, cushioning it and protecting it from all kind of damage. So, how do we see the picture here? So this is your frontonasal prominence. We can see that there is some kind of structure here. This is going to be the optic placode. We will talk about what does placode mean, but this is the optic placode. Optic placodes, there are two of them. They're responsible for your eyes, right? So they're responsible for giving rise to your eyes. So there's one here, and there's going to be one on another side. Somewhere here, looking like gills, right? So this thing right here, this is your pharyngeal gut tube that consists of a bunch of pharyngeal arches. This little tiny bulge that we can see here, this is a cardiac bulge. Surprisingly, you can see that for some time, the heart is going to be developing anteriorly to your pharyngeal gut tube. This is the pharyngeal gut tube. You can see that in front of it is the cardiac bulge located, right? So it's going to be for a very short period of time, but it is going to be anterior to it. Now, if this is the brain somewhere here, right? So it will continue to go down like this, something will continue to go down like this, and then come out somewhere here. What is this? This is going to be the neural tube. You remember last lesson yesterday, we talked about a particular process called neurulation, when neuroectoderm was folding into a tube, which was known as the neural tube. And this neural tube is responsible for giving rise to spinal cord and, more cephalically, a part of the brain. So on this picture, you can see that there are two neural tubes, but you must understand that it is the same neural tube. So do you see how the sectioning is located, right? So it is crossing your neural tube twice. So the part where it crosses here, right, is illustrated here. So this is the part of the neural tube which has been crossed here. And this little tiny part of the neural tube is located here. So do you understand a little bit the sectioning? Right? So you have an embryo like this, kind of sitting like this. You did the sectioning this way, right? So this way, you cut it to kind of see what is inside of the embryo. You cut it like this. And how does this picture look like? You literally put your embryo on its back right now and just seeing what is inside of the embryo. So I repeat, embryo was like this, right? We can see it's arched. That's where the neural tube is going to be located. We see it twice on this picture. You cut it, right? So this is more of a coronal section because that's the head. So it goes down like this, the sectioning, more of a coronal one. And then you flip your embryo on its back as it is indicated on this picture, and you're looking at inside. And this picture is really trying to show you the arches, that it is truly an arch. Do you see? It starts here and then it kind of goes deep and then comes out this way, right? So this is a pharyngeal arch. And then there's another one right under the same way. They're all arches, truly an arch-like appearance. So let's count how many pharyngeal arches do we have, right? So this is the first pharyngeal arch, right under it second, then third, then fourth, and then fifth. So you should know that originally we had 6 pharyngeal arches, but the fifth pharyngeal arch is rudimentary. It arises and disappears, immediately degenerates, immediately disappears. So how many arches do I have now? Well, 5, right? I had 6, 1 appears, disappears, so I have now 5. But what are their names? First, second, third, fourth, and sixth pharyngeal arch. So I hope it makes sense. You had 6 pharyngeal arches from the start, 1, 2, 3, 4, 5, 6. The 5th one disappears. So total number of arches is now 5. But how do you call them? 1, 2, 3, 4, 6. Eventually, these 4th and 6th pharyngeal arches, do you see they're very close to each other? 5th one used to be between them, but it's no longer there. So this 4th and 6th pharyngeal arches will eventually fuse together. And you should know that we don't really talk much about them because together 4th and 6th pharyngeal arches are responsible for giving rise to larynx and pharynx. Okay, so the two things together, larynx and pharynx, they will come up from 4th and 6th pharyngeal arches because they will fuse together and give rise to these structures. So let's take a look at the consistency, right? So what is it that makes up a pharyngeal arch? The most outer layer of the pharyngeal arch is, of course, the ectoderm. It is indicated on this picture as the blue line because it is literally facing outside. As you can see on the ectodermal surface, between the pharyngeal arches, there are some kind of deepenings. Do you see? There is a deepening here, there is a deepening there, and here, and there as well. So those deepenings on the ectodermal surface are known as the pharyngeal clefts. So if you have 5 pharyngeal arches, how many pharyngeal clefts are you going to have?
4.
4, right? So this is 5 pharyngeal arches. Count the deepenings between them. 1, 2, 3, 4, right? So you're going to have 4 pharyngeal clefts. Now, on the inside of the pharyngeal arches, the one which is actually facing the kind of lumen, right? So facing the inner part of it, in yellow color, this is, of course, your endoderm. So what are the pharyngeal arches lined by? By the endoderm. And you can see that they also have some kind of deepenings on the endodermal surface. And these deepenings are known as pouches, pharyngeal pouches. So remember that clefts are on the outside, lined by the ectoderm. Pouches on the inside, lined by the endoderm. And of course, there are also going to be 4 of them, the same as for the clefts. The problem with this topic, which, by the way, what we're discussing right now is not one topic, it's actually many, okay? It's like 5, 6, they kind of broke it down into many, is that you have to really know anatomy to understand what these pharyngeal arches, clefts, and pouches give rise to. And on several occasions, you're going to see that there is truly no understanding as in why this particular pharyngeal arch gives rise to this particular structure in the face. Like there's no understanding. So there will be a little bit of memorization in this particular topic where you will just have to memorize that this particular muscle will come from this particular arch. So of course you understood that each pharyngeal arch will give rise to something else. So will the cleft, and so will the pouch, but it will be fine. What is in the core of the pharyngeal arch, right? So we said that outside is the ectoderm, inside is the endoderm, so the inner lining. But what about the core? The core will consist of the paraxial mesoderm. You remember that it gives rise to the axial skeleton, and of course half of your face and the neck belongs to the axial skeleton. So of course it's going to give rise, of course paraxial mesoderm must be here. Lateral plate mesoderm. Last lesson we talked about that lateral plate has a V shape, right? How did we call the top part of the V? Parietal mesoderm or intraembryonic somatic mesoderm, and the lower part of the V was
visceral
mesoderm or the intraembryonic splanchnic. mesoderm. So of course you can understand that the parietal mesoderm is going to give rise to the parietal layer, right? So so basically on the inner part, so behind your oh my goodness, behind your muscles, okay? So behind the muscles of the neck, there will be a little bit of the parietal layer there as well. And visceral will be right on the top of the thyroid gland, for example, which is here, and etc. So these two layers will be present. These two layers are present in your neck right now, but they came from the mesoderm, and that mesoderm was part of this particular arches. So each of this arch had parietal and visceral mesoderm inside of it. So it has paraxial mesoderm, it has lateral plate, it has mesenchyme. You must remember that mesenchyme is embryonic connective tissue. And where does connective tissue come from?
Mesoderm.
Mesoderm. So be that paraxial mesoderm or lateral plate mesoderm, it gave rise to a mesenchyme in these particular regions of the arches. So that's the third thing that is present in the core. And we're also going to see the neural crest cells, right? Because they absolutely adore the mesenchyme. They like to stay there, divide there. So yeah. And last lesson, I told you that face, right, is very much related to neurocrest cells. So these neurocrest cells will definitely participate in making your face as it is. So in the cephalic region, we're going to have lots of neurocrest cells. Now, each of your pharyngeal arch is a very greedy structure. They don't share blood or nerves. So there's going to be an individual blood vessel for each of this pharyngeal arch, and there's going to be an individual nerve for each of these pharyngeal arches. This is kind of an explanation as in why some muscles are innervated by this nerve, while some muscles are innervated by other nerves. If they ask you why is that, because they have a different pharyngeal arches origin, right? So they don't share the blood vessels or the nerve fibers. Okay, so let's take a look at the structure here. So this is again your embryo, right? So this structure right here is your frontonasal prominence, right? So behind it, we're going to see the brain. We can see the optic placote right here, which is the future eye. Somewhere here, there's going to be an otic placote, an ear placote, okay? But we'll talk about it next semester, neurohistology, neuroembryology. This structure right here, this is the first pharyngeal arch, because do not forget that the first pharyngeal arch has two prominence, right? So it has the maxillary prominence and mandibular. Then we have the second pharyngeal arch, third, fourth, and sixth eventually, right? So the sixth will be somewhere here. They didn't indicate it, but it will be there. It's important to remember that maxillary process of the first pharyngeal arch is considered to be dorsal, while the mandibular process is considered to be ventral. Could you tell me why?
Because the ventral means closer to the trunk.
Perfect. So do not forget that dorsal and ventral are not only, the meanings are not only anterior, posterior, right? So it also means closer to the trunk or away from the trunk. Like when you're standing in the anatomical position, the palmar surface of your hand is facing the trunk. So as a result, it is considered to be a ventral surface, right? The back of your hand is considered to be dorsal because it is facing away from the trunk. So if you look at these two, maxillary and mandibular arches, one of them is closer to the trunk. So of course it's the mandibular. So as a result, it is considered to be the ventral one, while maxillary is going to be the dorsal one. Inside of the mandibular prominence, it's a mistake in the book, it's not an arch, right? It's a prominence of the first pharyngeal arch. Inside of the mandibular prominence, we can see a cartilage. And this cartilage is known as the Meckel's cartilage. And you have to be careful because in your first histo self-control test, when we looked at the embryo rat teeth, there was a slide where we could see Meckel's cartilage. Okay, so it was visible there. So please go back and try to find it. Okay, so they usually ask you this question if you picked that particular slide. There was a one slide out of like 6 or 7 that we have for teeth where Meckel's cartilage was visible. What is the purpose of the Meckel's cartilage? Meckel's cartilage is sort of like a draft work for making mandible. So let me make it clear that Meckel's cartilage does not give rise to mandible. Okay, mandible does not come out, does not arise from the Meckel's cartilage. If it did, then the ossification would be endochondral, right? Because this is a cartilage. And if it gives rise to the mandible, then mandible would arise through the endochondral ossification. But as we know, all of your bones in the face arise via the intramembranous ossification. No cartilage is used to make bones in your face. So Meckel's cartilage does not give rise to the mandible. You can think about it as this draft, right? So as this like particular pre-form that helps you to shape the mandible that is going to be in the future. So this is how we make the true mandible. The mesenchyme around the Meckel's cartilage differentiates and becomes osteoblast. So directly, mesenchyme around the Meckel's cartilage differentiates and becomes osteoblast. These osteoblasts start to secrete the osteoid, right? So the pre-bone itself. And they slowly start to deposit it on the surface of the Meckel's cartilage. As this happens, Meckel's cartilage starts to degenerate. And the more it degenerates, the more space for the osteoblast to make osteoid appears. So think about it this way. It's like, I don't know, you had the Meckel's cartilage here, right? Osteoblasts are around it, trying to make a bone like this. But then what happens? Meckel's cartilage starts to disappear. And the more it disappears, right, the more space to fill in the gap that is now left by the Meckel's cartilage. So this is going to be your true mandible, which now is a true bone, right? So there is no cartilage anymore. So to make a mandible, Meckel's cartilage has to disappear completely, okay? So to make a mandible specifically, it has to disappear completely to make sure that there is a space for the osteoblasts around it to make the bone. There are only a couple of remnants of the Meckel's cartilage, and they are located in the ear. There are 2 remnants of the Meckel's cartilage in the ear, and this is going to be incus and malleus bones of the ear. As you know, ear has 3 little tiny bones, right? Stapes, incus, malleus. So incus and malleus are actually arising from the Meckel's cartilage. Okay, so they do come from the Meckel's cartilage. So if they ask you this particular question, in the head region, right? In the head region, do all of the bones ossify intermembranously? The answer is no. We have 2 exceptions. In the ear, right? So incus and malleus, they will ossify endochondraly because Meckel's cartilage will be ossified and it will become the incus and malleus. And also the base of your skull. So the base, okay, where the brain is sitting on, right? So the base of the skull, it will also not be ossified intramembranously, it's going to be ossified endochondrally. So those are the two exceptions in the face. What about maxillary processes and Meckel's cartilage, right? So, and mandibular processes, what are they going to give rise to? What else? Maxillary process will give rise to the following things. You can cross out premaxilla, it doesn't give rise to it. So maxillary processes will give rise to maxilla, zygomatic bone, and part of the temporal bone. Okay, so of course, anatomy, just think about it this way, maxillary processes are here. So all of the bones that are going to be present here will arise from maxillary processes. How exactly? Intramembranous ossification. Okay, so intramembranous ossification. What about the muscles? Muscles of mastication, of course, right? So think about maxillary process, mandibular process. Which kind of muscles do we have here? Muscles of mastication, such as temporalis, right? Pterygoid, masseters, and anterior belly of digastric. Mylohyoid, tensor palatini, tensor tympani. The most important is anterior belly of digastric and muscles of mastication. Okay, you have to remember that these muscles do come from the first pharyngeal arch, specifically anterior belly of digastric. We have said that pharyngeal arches are very greedy, right? So they don't share the blood vessels, they don't share the nerves. What is the innervation of the first pharyngeal arch? Well, very easy. Maxillary processes are innervated by maxillary branches of trigeminal, and mandibular are by the mandibular. The blood vessels, I didn't write them here because we're going to talk about it next lesson. Okay, all of the blood vessels of the face and neck and etc. We're going to talk about it next lesson. But of course, you can guess that it's going to be maxillary artery, right? So maxillary artery, we just have to learn where does the maxillary artery come from. Okay, so those are the things that the first pharyngeal arch gives rise to. What about the second pharyngeal arch? As you can see inside of the second pharyngeal arch, there is also a cartilage, which is kind of in blue color. This cartilage is known as the Reichert's cartilage, right? So we're going to call it the Reichert's cartilage. Another name for the second pharyngeal arch, it is also known as the hyoid arch. But this name is very misleading because you would think that if it is called hyoid arch, right, the entire hyoid bone will come from it. But it is not true. Hyoid bone is made partially by the second pharyngeal arch and partially by the third one. So two pharyngeal arches are participating in making one hyoid bone. So here we can see a little bit later, right? So as an adult, what will Reichert's cartilage give you? Unlike Meckel's cartilage, Reichert's does not disappear. It actually gives rise to some things. It gives rise to stapes. It gives rise to styloid process, stylohyoid ligament, and as you can see, the upper part of the body of the hyoid bone together with the lesser horns. The rest of the body of the hyoid bone, together with the greater horns of the hyoid bone, will come from the third pharyngeal arches. So remember that this bone is quite special, right? So it is made by the two pharyngeal arches together. So we have talked about the bones that are arising from the second pharyngeal arch. What about the muscles? Very importantly, posterior belly of digastric. That's usually the question. Okay, so tell me the origins of the bellies of digastric. You have to say anterior comes from first, posterior comes from second, because they come from two different pharyngeal arches. This explains their different innervation. As you know, posterior belly of digastric is innervated by the facial nerve. So you must know that the nerve of the second pharyngeal arch is going to be facial nerve. That also explains that all of the muscles of the facial expression are also going to come from the second pharyngeal arch. And that should make it actually quite interesting for you, because some of the muscles are a bit more superficial, right? The facial muscles are a bit more superficial, while the masticatory muscles, some of them are a bit deeper. So that is very interesting that in some places of your face, the second pharyngeal arch muscles kind of protruding forwards, while the first one stay behind, right? And you can see that on this picture, it's kind of the opposite. So first is a bit more superficial and second is a bit deeper. So facial nerve is the one which is innervating the second pharyngeal arch. Okay, third pharyngeal arch, very easy. We have said that it makes the rest of the hyoid bone, right? So this body together with the greater horns, stylopharyngeal muscle is the only muscle that the third pharyngeal arch makes. It also explains that this is the only muscle in your pharynx-larynx situation that is not innervated by the vagus. It is innervated by the glossopharyngeal nerve. So now you know why, or if they ask you why, you're going to say that the reason this is the only muscle in the pharynx that has nothing to do with the vagus, right, is because it didn't come from the fourth, sixth pharyngeal arches. It came from the third pharyngeal arch, and the innervation of the third pharyngeal arch is a glossopharyngeal nerve. Fourth and sixth, you can see that there is a dash between them because later they will fuse, right? So fifth pharyngeal arch used to be between them, but it appeared and disappeared. So fourth and sixth will slowly approach one another and will eventually fuse together. Fourth and sixth are responsible for giving rise to your larynx and pharynx. Just remember that thyroid cartilage, majority of it will come from fourth. Cricoid, majority of it will come from sixth. Sometimes they ask this, right? So which one will come from where? But think anatomy, right? Thyroid is more up, cricoid is more lower. So of course, fourth, sixth, they will go down like that. What about the innervation? Because fourth and sixth will eventually fuse, vagus will innervate both of them. So both of them get their innervation from vagus, but don't forget we can't really share a nerve. So different branches of the vagus. Fourth one is going to be innervated by the superior laryngeal nerve, and sixth one is going to be innervated by the recurrent laryngeal nerve. So two different branches of the vagus are responsible for innervation of the two different arches. Now, what about clefts and pouches, right? So we talked about the different arches, what they give rise to, but what about clefts and pouches? So you remember that the clefts are located on the outside, on the ectodermal surface, while the pouches are located inside on the endodermal surface. We had 4 pharyngeal clefts. We're going to see that approximately around 1.5 months of age, okay, of embryo, the second, third, fourth pharyngeal clefts start to fuse together, and eventually they will disappear. Because take a look, if you look at your lateral part where the cleft should be, right? There's only one opening. There's only one opening on your ectodermal surface, which is laterally located, and that's your ear itself, right? On your neck region, where the second, third, fourth pharyngeal cleft used to be, there's nothing. So this is good for us because eventually we're going to be left out with only one pharyngeal cleft, the first one. And this first pharyngeal cleft is going to be responsible for giving external auditory meatus, right? So your external ear, this auditory, how do you say it, the what's another name? I forgot it. This little external auditory meatus, external auditory something else it's called. Okay, so this part of the tube, because auditory tube is something else. Okay, it's the internal one, but this pathway from the outer ear until the tympanic membrane, right? So this little tiny route, right? So this is going to be coming from the first pharyngeal cleft. Easy. What about the pouches? They persist, and the way things are made here is actually quite interesting. First pharyngeal pouch is very special. So here the endodermal tissue of the first pharyngeal pouch keeps on proliferating until it meets up with the first pharyngeal cleft. So first pharyngeal pouch, right? The endoderm here keeps on pushing, keeps on proliferating until it meets up with the first pharyngeal cleft. So if this is your cleft and this is your pouch on the inner surface, it keeps on pushing this way until it actually meets up. The meeting point between the cleft and the pouch, this is your tympanic membrane. So you should know that on the outer surface of the tympanic membrane, the epithelium there is from ectoderm, while behind the tympanic membrane, the epithelium there is endoderm. Tympanic membrane is very special, okay? It has two types of epithelium. We will learn about it next semester, neurohistology, but just remember that this is quite important to know. The tympanic membrane has dual epithelium, depending on which part you're looking at, right? So from the outside, it is ectodermal. From the inside of the ear, it is endodermal. So if this is the tympanic membrane, of course, you can understand that the proximal part is going to be the auditory tube, right? And the proximal is the one which is closer to the lumen, right? So auditory tube, and the part between them, this is like your middle ear. So the tympanic cavity, middle ear, is going to be right here, so a bit distally, right? So this is the distal and this is the proximal. So auditory tube, it's kind of like your inner ear, okay? So it has a connection to your inner ear. But for sure you know this cochlea, okay? So the one which is responsible for hearing, it doesn't come from any of these things, nothing. The cochlea, together with the vestibule, together with the semilunar canals, will come from the otic placote. Remember we said that somewhere here, there's going to be an otic placote. So what is placote? Placote is a thickening of the ectoderm. So it is stratified something epithelium, okay? So majority of the time it is cuboidal. So stratified cuboidal ectodermal epithelium. Like everywhere else it will be simple, but placote is going to be stratified epithelium. And we have three types of placotes. We have the optic placote. We'll talk about them next semester, neuroembryology, neurohistology. They give rise to majority of the things in the eye. We have the otic placote. They give rise to the nerve parts of the inner ear. So like cochlea, vestibule, semicircular canals. And we have the nasal placotes. They will give rise to your nose. We'll talk about it today. Okay, second pharyngeal pouch, the endoderm that we have here starts to invade the mesenchyme of the second pharyngeal arch. So there's going to be a mix of tissues between the endoderm and the mesenchyme. And this mix of tissues, specifically at the level of the second pharyngeal pouch, is going to give rise to the palatine tonsils. So how do the palatine tonsils appear? When the endoderm of the second pharyngeal pouch invades the surrounding mesenchyme, and this mix of tissue gives rise to the palatine tonsil. The same invasion, where endoderm invades mesenchyme, happens at the level of the third pharyngeal pouch as well. But for some reason, and nobody knows why, it gives rise to different organs. It doesn't give rise to palatine tonsil. So for sure, there's some kind of genetic regulation involved, right? So why the same process happens at the level of second and third pharyngeal pouches, but different outcomes are there. So at the level of the third pharyngeal pouch, the endoderm invades the surrounding mesenchyme and gives rise to two things. A bit more superior, right? A bit more superior in yellow. It gives rise to the inferior parathyroid gland. And a bit more inferior in red, it gives rise to the thymus. What is the purpose of the thymus? What is it responsible for? What does thymus do? Oh, come on, guys. Thymus is responsible
T
for
lymphocyte maturation.
T lymphocytes maturation. Okay, so this is the place, it's an immune organ. It's a very important lymphatic organ. This is the place where T lymphocytes are made, right? So where they mature, where they're made, and etc. Okay, so thymus and inferior parathyroid glands are arising from the third pharyngeal pouch. Fourth pharyngeal pouch is very special because here we have also the same invasion. I mean, endoderm invades the mesenchyme, but additional cells participate in making a very specific structure, and these cells are neural crest cells. So as you can see, the fourth pharyngeal pouch gives rise to the superior parathyroid gland and ultimobranchial body. So ultimobranchial body is the one that has been made with the neural crest cells. So neural crest cells have definitely participated in making this structure. So we have the following organs, right? So we have the palatine tonsils when endoderm invades the mesenchyme, second pharyngeal pouch. Third one, we have the inferior parathyroid gland and thymus, the same process. Fourth one, we have the superior parathyroid gland and ultimobranchial body. And don't forget that ultimobranchial body is special because it actually has neural crest cells in it. So is this normal anatomical position for you? Of course not, right? So superior parathyroid gland cannot be inferior to inferior one, right? So this is why it has to be modified. Some kind of changes must appear. So what are those changes? We're going to see that, first of all, you need to remember what is the purpose of the ultimobranchial body. Ultimobranchial body, or specifically the neural crest cells that have given rise to the ultimobranchial body, are responsible for giving parafollicular cells of the thyroid gland. You remember the C cells, right? So these parafollicular cells are giving rise to they're secreting the calcitonin. That's why they're called the C cells. And calcitonin, as you remember, lowers the calcium level in the blood. And do you remember to which family they belonged, the parafollicular cells?
APUD.
APUD family, APUD, and you remember that APUD family is very special, right? Can't be seen with H&E, needs silver because they all come from neural crest cells, and etc., etc. So how do we assume the normal position? The two thymuses that we have here detach from the third pharyngeal pouches and come to the middle. Okay, so the two thymuses will detach from the third pharyngeal pouches and come to the middle. In the middle, they will fuse together and give rise to one thymus as we know it. This thymus is supposed to descend all the way down to be all the way behind the future sternum, right? So of course you must understand that there is a genetic process involved. We just don't talk about it. There are like a couple of genetic processes that they ask you, and what I will teach you when the time comes. But here they don't want to know this. Just remember that the two thymuses detach, come to the middle, fuse together, descend down to be behind the sternum. What's interesting is this, that when the two thymuses are detaching, so do the inferior parathyroid glands. So two thymuses are not the only ones that are detaching from the third pharyngeal pouches, right? The inferior parathyroid glands are also detaching and are also meeting in the middle, but then they attach to the superior surface of your one thymus, like a Mickey Mouse, you see? So this is your thymus, and this is the two inferior parathyroid glands. So in a way, they're kind of hijacking, right? So they're just getting a lift until a certain destination. They're just attaching to thymus, so thymus can take them a little bit downwards. At the level of the fourth pharyngeal pouch, the two inferior parathyroid glands detach, they're detaching and attaching to the inferior surface of the ultimobranchial body. Thymus continues to descend down. So is it clear about the inferior parathyroid gland? I'm going to repeat it again. When thymuses detach and meet in the middle, so do the inferior parathyroid glands as well. But they don't fuse. They simply attach to the fused thymus and descend with it down. At the level of the fourth pharyngeal pouch, the two inferior parathyroid glands are detaching from the thymus and attaching to the inferior surface of the ultimobranchial body. Thymus continues to descend down. A very common question that they can ask you is this. If you do not see inferior parathyroid glands on the surface of the thyroid gland, as you know, thyroid gland, right, behind it, we have two superior parathyroid and two inferior parathyroid. So you're looking at the cadaver or, I don't know, ultrasound, and you do not see parathyroid glands. You don't see the inferior ones on the thyroid gland. What is the next organ that you should check up? Where could they be?
Thymus.
Thymus. Okay, you go behind the sternum. You're looking at the thymus, its superior surface. Because if you cannot find inferior parathyroid glands on the thyroid, it simply means that they haven't detached from the thymus. So thymus have taken them all the way down behind the sternum. Are they functional? Yes. As long as they get blood supply, they will be functional. They will be secreting the PTH, right? So the parathyroid hormone, and it will be fine. It's actually quite common anatomical variation. Okay, so some cadavers actually do have it. Okay, guys, let's talk about development of the face. How do we make the face? You're already familiar with the frontonasal prominence, right? So has the outer ectoderm. Inside it has mesenchyme filled with neural crest cells. You're familiar with the two maxillary prominences and two mandibular prominences, right? So together they're making up the first pharyngeal arch. There is an opening which is known as the stomadeum, right? But now you can see two new things on the surface of the frontonasal prominence. There is in black, this is the optic placoat. It's not an eye, it's an optic placoat. This optic placoat is the thickening of the ectoderm on the surface of the frontonasal prominence, and it will give rise to the eye itself, right? So the retina and all of those things. But we're more interested this semester about the nasal placoats, and there are two of them, and this is one nasal placoat. So this whole thing, this is a one nasal placoat, and there's another one on the side. So really look into the face of a 5th week embryo, because the eyes are somewhere here, okay? The eyes are somewhere here, and one nasal placoat is here, one nasal placoat is here. To make a nose, these two nasal placoats must meet in the middle. They should fuse together. So keep that in mind. So two of this nasal placoat must fuse together to make one nose. What does the nasal placoats consist of? They also have some kind of prominences. In yellow, these are the medial nasal prominences. In blue, these are the lateral nasal prominences. And between them, there is a deepening, which is known as the nasal pit. Okay, so there is a deepening known as the nasal pit. So think about it this way. This is your one nasal placoat, like this, right? So it's a very prominent structure. It's thick, right? It's stratified epithelium, one nasal placoat, deepening on its surface like this. This is going to be the nasal pit. Closer to the middle, this is the medial nasal prominence. A bit away, this is the lateral nasal prominence. That's what your nasal placoat consists of. But it's very important to understand the relations of the nasal placoat to the surroundings. So we're going to take this whole thing and we're going to magnify it and redraw it. So do you see that in orange, this is a maxillary prominence right here. So we're going to redraw it here like this. So this is a maxillary prominence. Maxillary, right? So this is a maxillary prominence. In its corner, somewhere here, there is an optic placoat, right? So somewhere here, this is where the optic placoat is going to be in the future eye. Somewhere here, we can see the lateral nasal prominence, which is sitting on the surface, right? It's right there on the top of the maxillary. Do you see in blue, right? So this is the lateral nasal prominence sitting on the surface of the maxillary. The medial one, which is in yellow, and this picture doesn't really give it justice. If we draw the medial, it will be something like this. It will go down in front of the maxillary and then come up again. Okay, so this is going to be the medial nasal prominence. So it's not just sitting on the top of the maxillary, it's also kind of sitting in front of it, right? So do you see this part? This part of the medial is very important because it is located a bit in front of the maxillary. And what is this opening right here? This is, of course, your nasal pit, right? So this part right here, this is the nasal pit, the opening into your nose. So how do we make a face? By the way, whenever they ask you, when did the structure arise, right? So which week did this organ or the structure started to appear? In approximately 80% of the time, you can say 4th week and you will be right. So if you're not sure, you don't remember which organ appeared when, okay, or which part of the body appeared when, say 4th week, there's an 80% chance that you're right. Because there's just some exceptions that appear 3rd or 6th or 5th or etc. Okay, but for example, face 4th week. we start making the face at the end of the 4th week, beginning of the 5th week. That's when it starts to appear. So from the 4th week, what happened during the 4th week, by the way? Nasal placodes. Okay, so the 2 lateral and medial nasal prominences have appeared then. So what happens later, right? So what happens after the 4th week? After the 4th week, in the next 2 weeks, after the 4th week, the 2 maxillary prominences start to expand dramatically. They grow a lot. And they grow specifically in this direction. So they grow this way. What is it this way? Towards the middle. Okay, we can see that there's 1 maxillary prominence here. There's another maxillary prominence here. And starting from the 4th week, in the next 2 weeks, they start to expand this way. They're growing towards the middle. If your maxillary prominence is pushing towards the middle, what is in front of it? A medial nasal prominence, right? So of course it will push it towards the middle as well. So by the 7th week, we see something like this. Okay, so this is the 7th week. What are the changes? Well, there's still maxillary prominence. They have expanded dramatically. They have pushed towards the middle. But most importantly, they pushed the 2 medial nasal prominences together. And as a result, they have fused together into 1 medial nasal prominence. What are the blue things? Of course, that's your lateral nasal prominence. And the 2 openings that we have here, these are the nasal pits. So take a look at this picture. This is a newborn baby, right? This is a 7th week embryo, and this is a newborn baby. In the newborn baby, we have to identify where did some of the things come from. So tell me, lower lip, where did the lower lip come from?
Mandibular prominence.
Mandibular prominence. So don't forget this entire area, like down like this, right? This is your whole mandibular prominence. Don't forget we started with 2, but they fused in the middle. You know, sometimes people have a gap here. It's very genetic, specifically in boys, right? Boys get it from their father. That's how it's the cheapest genetic test there is to know if you're truly the son of your father. If your father has this gap right here, you will have it 100%. And if you don't, that's not your father. It's like the easiest genetic test. For girls, it's a bit because this is not a dominant gene in girls, but still in boys, it's very sufficient. So you can actually kind of also touch it a little bit and try to find it. Okay, there is a little tiny gap on the tip of your mandible. In some people, it's very prominent. If you don't feel it, that means it's not prominent in you. What does it mean? It means that your 2 mandibular prominences have fused very nicely. Okay, they have reached each other, fused together into 1. If you do have a gap right here, that means that they didn't fuse nicely, right? So they did approach each other, but there was no complete proper fusion, that it left a little gap right here behind. And this is actually, as I said, a very dominant genetic defect. It's not really a defect, but it's like a malformation of some sort here. But again, when I say malformation, you're not going to die from it. It's just like anatomical variation, right? So which is on your chin. So of course, all of this lower part will come from your mandibular surface, mandibular prominences. Now, what about the blue things, right? So what are these? These are, of course, the wings of your nose, the ala, right? So ala of the nose, these little lateral surfaces, they have come from the lateral nasal prominence. The crest, right? And the crest and this is the crest of the nose. This is the tip of the nose. So crest of the nose, tip of the nose. This is a medial nasal prominence, of course. So all of the cartilage there including the nasal septum. So think deep into your nose, right? Nasal septum will for sure come from the medial nasal prominence. But do you know, in anatomy 1, we have learned that there is like this bony structure here. Like, I don't know how to really draw it. The bony part, which is between your two eyes of the nose. You can feel it here right now, right? So this is the bone of your nose. The bone of the nose actually does not come from the medial nasal prominence. It comes from the frontonasal prominence. Frontonasal prominence gives rise to this bone right here, the nasal bone itself. Not the cartilage, right? Not the crest and the tip, but the bone itself. So now we're going to talk about the upper lip, right? So how did we make the upper lip? The corners of the upper lip are made by the maxillary prominences. You can clearly see it here, right? So they made by the maxillary prominences. But the center of your lip, the upper lip, the center, is made by the medial nasal prominence, right? So it is made by the medial nasal prominence, this one. So upper lip, corners maxillary, middle medial nasal prominence. Philtrum, right? So behind and in front, there are two philtrums. So this little gap here that we have, right? So this one from the nose, philtrum, it's also going to be made by the medial nasal prominence. Do you guys know any diseases that could have arisen here? And I'm wrong for saying diseases, malformations. Malformations that could happen here. Are you familiar with a cleft lip? Right, so I go here, we're going to talk about it, right? So this is a cleft lip, right? Cleft palate. This is a cleft palate. So these ones, this is a also cleft lip. They appear when maxillary prominence does not fuse with the medial nasal prominence, right? So they do not fuse. So if maxillary and medial nasal prominence do not fuse, there's going to be a gap here. And this gap is known as the cleft lip. So if they ask you what is the malformation that could be here, right? This is the cleft lip. So everything that we're talking about here is very superficial. So now we have to go to a deeper level, because you must know that your maxillary prominences are not just here, right? They go deep into your face, right? Maxilla is a very huge bone that is going deep all the way into your face. Specifically, what we have to talk about is your palate, the roof of your mouth, okay? So your hard palate, that's what we have to talk about. So there is a new word that they introduce in your book, and this is known as the intermaxillary segment. What is intermaxillary segment? It is your fused medial nasal prominence, but at the deeper level. So I repeat, intermaxillary segment is the fused medial nasal prominences, but at the deeper level, so in your mouth. So try to see everything that is in yellow here. This is your intermaxillary segment. This is your lip. This is your lip. How do we call the area where the 4 incisor teeth are located? Just this 4 teeth. How do we call the bone there? It's actually called premaxilla. It's a mistake here. Okay, they always ask you this. Premaxilla. Premaxilla is not maxilla before birth or something like this. Okay, so premaxilla is this. It's this little part of the maxilla where the 4 incisor teeth are located. Behind the premaxilla, we can see this triangular area. This is known as the primary palate, right? Behind your teeth. So there, this is the primary palate. And could you tell me what is in the apex of the primary palate? What is going to be here?
Foramen cecum.
I think not. Incisive foramen, yes. Incisive foramen is the one that is going to be there. So remember that it's right there at the apex of the intermaxillary segment. So I repeat, this whole thing in yellow, right? This is your fused medial nasal prominences, but at the deeper level, deep. So right there. At the tip of it is going to be the incisive foramen right here. Maxillary processes, we saw them here, right? We saw them right here. They go deep into your tissue like this, one here, right? Create some kind of outgrowths. These outgrowths are known as the palatine shelves. And these palatine shelves originally are under your tongue. So half of your hard palate is here, half of your hard palate is here, right there under your tongue. What should happen? They should ascend, they should go up a little bit, and wait for the nasal septum to come down so all of the three tissues can fuse together. Okay, so nasal septum should fuse together with the two palatine shelves to create a structure which is now known as the secondary palate. So this thing right here, this is your secondary palate. Remember that the primary palate was just a little tiny triangular area right here, right? Okay, so sometimes in some babies, it stays like this. So the two palatine shelves do not fuse, they stay like this. And this is known as the cleft palate. And could you tell me, why is it bad? Why is it bad? Like, what could go wrong? Why is it not?
It can be open to the nasal cavity.
Of course, it can be open to the nasal cavity. That is true. Yes. So there could be like there's a connection between them, communication. So that's not good. Prone to bacterial infection and etc. But think about it. What do we use hard palate for? Why is it important to have hard palate?
Chewing.
Chewing, but don't forget newborns don't chew, right? They suckle on the nipple during breastfeeding. And specifically, how does this happen? The tongue of the newborn takes the nipple of the mother and pushes it against the hard palate to make sure that the milk comes out. So babies with the defect such as this, the cleft palate, they can't be fed. They can't, even if you give them a bottle, right? Not, for example, the breast of the mother, a bottle. A bottle still has the shape of this particular, like the tip still has the shape of a nipple. So you need to suck it out. There is a breastfeeding, there is a feeding issue, a major feeding issue with the babies like this. So you have to actually insert the catheter into a nose, and this catheter would be going into the stomach, and you will be putting the milk through this catheter. It's a major issue in these babies who have a hard palate. So it has to be fixed immediately. If the cleft lip can wait, right, the cleft palate cannot wait. So unfortunately, they will be asking you this. So about these two disorders. So I repeat, cleft lip appears when maxillary prominence does not fuse with the medial nasal prominences. They do not fuse. There is a gap here. It's simply a cosmetic issue, right? It's simply appearance issue. It doesn't really cause any functional abnormalities. It just looks weird because take a look, right? So this is your cleft lip right here. There's a hole. There's a hole all the way to the nose. Cleft palate, do you see? There is a hole. The baby does not have the hard palate. There's a hole. What you're looking into right now, this is a nasal cavity. You're looking straight into the nasal cavity. So this is providing some functional dysfunction, right? So the baby cannot be fed. So I hope you understood that. What can cause cleft lip or cleft palate? Genetics, of course, smoking during pregnancy, and this is very important, exposure to teratogenic drugs. In your embryo 1 topic, so the one which is in the histo room, there is a topic about this teratogenicity. Okay, so what does it mean? Of course, we didn't talk about it in your embryo 1 because it's more for the embryo 2. So we are going to have an additional PowerPoint where I'm going to go over all the new things in the embryo 1 that is part of the histo room. Teratogenicity, it means that you can modify the embryo somehow. Okay, so this is a substance that can somehow cause harm or some kind of pathological modification to an embryo. And could you tell me from embryo 1, which period of the embryo is the most susceptible to teratogenic drugs? Embryo has 2 periods, until a certain time and then after that time. What is that time? This is going to be 3rd to 9th week of embryogenesis. So 3rd to 9th week. This period is known as the period of organogenesis. This is the time when embryo is busy making all of the organs. And this is the period when you're most susceptible to teratogenic substances. Okay, so for example, if a mom is smoking during this period, it can cause more damage to the embryo. If she's taken certain antibiotics during this period, the baby can be born deaf or blind or something, right? So it modified the embryo somehow. Anticonvulsants, these are drugs that a woman takes when she has epilepsy. Do you guys know what is epilepsy? Maybe you know, like in movies sometimes they show seizures, like a person is standing still and then they fall down and they start shaking, there's foam coming out from their mouth, right? So seizures, this is abnormal electrical activity in the brain where brain is just firing up lots and lots, so you're falling down and seizuring, but not always. Some children have something that is called absence seizure, where they just stare, right? So no movement whatsoever, they're just staring at you for like a short period of time and then they continue doing something else. So without going too much into details, you have to take anticonvulsants, you have to take certain drugs that prevent you from seizuring, prevent you from having like epilepsy, right? Unfortunately, all of these drugs are teratogenic drugs. And a woman who has epilepsy and she's pregnant, from 3rd until 9th week, she cannot take anticonvulsants. She can't, okay? Or you tell her that she can, but there is a chance that the baby will be malformed, such as cleft palate, or cleft lip, or deaf, or blind, or worse, just a miscarriage, like complete miscarriage. Maybe you know this. How can we prevent all of this? There is a certain substance that they make you take when you're pregnant. It's important that you take this vitamin. Folic acid, have you ever heard this before? Folic acid?
Vitamin C.
Vitamin C as well, but folic acid, foliate, have you ever heard this one? Okay, so folic acid. So folic acid is more important than vitamin C because it's protecting the neural tube of the embryo, and this is the most important. If embryo's neural tube is protected, there are less defects like that. So if nervous system of the embryo is intact, there are less defects like that. So like that's the solution basically. Okay, tongue. How can we make a tongue? To if you got this topic, I like strongly advise you to draw this. It's very difficult to explain how the tongue is made unless you drew this. So this is your pharyngeal gut tube, of course, right? So first, second, third, fourth, and sixth pharyngeal arches are here. On the outside, we have ectoderm. On the inside, we have endoderm, cleft, pouch, right? You get it. Approximately during 5th week of development, on the inner surface of the pharyngeal gut tube, right? So on the inner lining of the pharyngeal gut tube, we can see some kind of swellings. So of course they are endodermal swellings because they're on the inner side of it, right? So they're endodermal swellings. The 3 endodermal swellings on the surface of the first pharyngeal arch are called 2 lateral lingual swelling and 1 medial lingual swelling, which is also known as the tuberculum impar. Okay, so this is a medial lingual swelling. On the surface of the second, third, and fourth, right, you see that it kind of occupies all 3 of them. There is a prominence which is known as the copula. Another name for copula, it is also known as the hypobronchial eminence or prominence. And then there is the epiglottic swelling, and then there are the arytenoid swellings, but it's not important. So what's important is the innervation. Could you tell me what is the innervation of the first, specifically here? It's a bit down, right? So it's not up where maxillary prominence is, it's a bit down. So here the innervation will be the mandibular of the trigeminal. Second pharyngeal arch, which is in blue, right? So this area in blue will be innervated by, of course, facial. Area in yellow, which is the third pharyngeal arch, will be innervated by the glossopharyngeal. And area in 4, right, so in green, will be innervated by the vagus. So slowly, something is happening to your lateral lingual swellings. They are actively growing, spreading, and not only in this direction, also this direction. So try to compare the 2 pictures, right? So these are your 2 lateral lingual swellings, and this is your medial lingual swelling or tuberculum impar. The 2 lateral lingual swellings, they grow a lot, right? So they grow not only outwards, but they also grow a little bit inwards. Yellow area, right? So the floor of the third pharyngeal arch also expands the same direction. By the 5th month, your tongue is formed. So anterior 2/3 of the tongue, anterior 2/3, came from the swellings of the first pharyngeal arch, right? So which are the 2 lateral lingual swellings and 1 medial. Posterior 1/3 of the tongue came from the copula, right? So came from the copula, but specifically the copula, which is located at the level of the third pharyngeal arch. My question to you is, where is blue, right? Because on this picture, you cannot see the blue. Where is the floor of the second pharyngeal arch? The floor of the second pharyngeal arch is inside. It is right here, but inside. A very good representation would be if you take a piece of paper and you do something like this, right? So this is, okay, how can I do this? Just a sec, guys. So this is the first, this is the second, and this is the third, right? First, second, third. What am I talking about? Red color is the first, right? Blue color is the second, and yellow color is the third. So what happened is this. They kind of came close together, the first and the third, they came close together. So did the second disappear? Not really. As you can see, it is still there, but it's kind of inside of it. You can kind of even squish it like this. It's kind of inside of it. So the first and this is a 3, sorry, but it collapsed, right? So first and 3 are together, they're bordering each other, but the second one is inside, it's right under it. So what are we talking about? The first, the anterior 2/3 of the tongue is innervated by mandibular, specifically by the lingual branch of the mandibular, right? Because this is the most anterior 2/3 of the tongue. The posterior 1/3 of the tongue, as you can see, is made by the 3rd pharyngeal arch. So it has to be innervated by glossopharyngeal. Where is the second, right? So where is the blue area? Where is the second, the copula, which is here? It's inside of your tongue. It's inside of it. So it gives this special sensation, right? Chorda tympani of the facial. This is the taste. The most posterior of the tongue is the 4th pharyngeal arch, which is going to be somewhere here, and that's the vagus, right? So don't forget that glossopharyngeal and vagus, they innervate the most posterior part. So to describe where is the floor of the 2nd pharyngeal arch, I could really advise you to do this, because that's exactly what happened. They were straight, right? They were at one level. This 1st and 3rd grow a lot, and they grow towards each other, but they also grow in that and in that direction as well. So they grow a lot. So exactly, you could show it like this, that they did this. Okay, so they did this. So it's also very good. Another picture just to show you the same idea, right? So how copula and etc. I think it's worth mentioning that there is a foramen cecum here, okay? So between the tuberculum impar and copula, so between them. But you should know that by the 5th weeks, it's not there. It's a mistake in the book. It's not there yet. Foramen cecum is not present at the 5th week old embryo. You don't have it here. You do have it by the 5th month. Sorry. You do have it by the 5th month, but you don't have it by the 5th week. So let's talk about what is foramen cecum. And when you're describing the foramen cecum, when you talk about it, you're actually talking about thyroid gland. So thyroid gland consists of 2 types of cells, right? We have the follicular cells and we have the parafollicular cells. And I hope you remember that the parafollicular cells, they come from the ultimobranchial body. We just talked about it, right? So parafollicular cells, the C cells, the calcitonin secreting cells, they come from ultimobranchial body. So what we're going to talk about right now is where does the follicular cells come from? Follicular cells are going to be arising as endodermal proliferation. Okay, they arise as endodermal proliferation between tuberculum impar and copula, so between them, during approximately 4th-5th week. Okay, 4th-5th week, this is when the follicular cells of the thyroid endodermal proliferation arises right here between tuberculum impar and copula. Then this proliferation starts to descend down, because this is like on your tongue basically, right? So that's not where the thyroid gland should be. So it starts to descend downward. The problem is that it didn't detach. It just starts to descend. And if it starts to descend, of course, there's going to be a little tiny trail that still connects it to its point of origin, right? Think about it this way, like you started somewhere here, right? That's where your tuberculum impar and copula is located. Normally, you would detach from it and you will just start to descend downwards to go to where you need to go. but this endodermal proliferation, these follicular cells, as they descend, they have a connection to it, which is going to be my arm right now. So they still have the connection, some kind of duct. And this duct is known as the thyroglossal duct. And fun fact, my cadaver had it. Okay, our cadaver had it, the thyroglossal duct. So some kind of tube that is connecting your thyroid gland all the way to your tongue. So when we opened the mouth of our cadaver, from the tongue, there was something going down. And when we traced it, right, so it was this. So it's very weird how it was an old man and he didn't complain about it. So he didn't tell his doctor that I have difficulty swallowing. Can you imagine? There is a tube going down from your tongue all the way to the thyroid gland. It's very difficult to swallow. There's constant sensation that there is something present in your throat. But the person apparently did not complain about that. So what I'm trying to tell you, do you have thyroglossal duct? No. So this thyroglossal duct should degenerate. And when it degenerates, it leaves a little tiny mark from the point of origin. And that mark is a foramen cecum. And Zoli and some other professors, they really like to ask about it. What is this foramen cecum, right? So we have it on our tongue, a little tiny dot, a little tiny remnant of some sort. So foramen cecum is a remnant of degeneration of thyroglossal duct. So if thyroglossal duct degenerates, if it disappears, you will have foramen cecum. If it doesn't, you don't have foramen cecum. So our cadaver did not have foramen cecum. Okay, so there was nothing there because there was still a duct coming from there. By the 7th week, this is when your descending thyroid gland reaches its final destination, right? So which is going to be present here. In some people, thyroglossal duct does not disappear completely. It kind of remains halfway. So like the distal half of it degenerates and the proximal half of it persists. This is known as the pyramidal lobe of the thyroid gland. As you know, it usually just have 2 lobes connected by the isthmus, but in some people there is a 3rd lobe coming from the isthmus up like this, the pyramidal lobe. And if you have it, it is a remnant of the thyroglossal duct. Okay, so this is half of the thyroglossal duct that didn't disappear, right, that it stayed. In other people, thyroglossal duct leaves additional remnants, so little tiny cysts that stay. Okay, so it's like in some places this duct did not disappear fully, it just leaves some kind of little tiny cysts. These cysts are known as the thyroglossal duct cyst. Okay, it's an abnormality of some sort. In the anatomy department, they say it looks like goiter. It just proves that the anatomy department, like how many people there actually have MD, like 5 or 10, okay? They have 5 or 8 actually have a medical degree, so they actually know how a goiter looks like. For sure, you know what a goiter is. It's like this huge swelling of the neck in some people when they have hypo or hyperthyroidism, like a huge swelling, okay, goiter. This is not how goiter looks like. This little tiny bump, that's not a goiter. If you will have a goiter, sometimes they actually call it bull's neck because it's huge swelling this way. Okay, it will have like this big thyroid gland. But okay, sometimes they say that thyroglossal duct cyst resembles goiter. You could argue, okay? You could argue there. You could say, well, technically it doesn't. So yeah, it's just some remnant of the thyroglossal duct in some people. So doesn't disappear fully. We should know that thyroid gland starts to function at the end of the 1st trimester. So at the end of the 3rd month, already calcitonin is being secreted by the parafollicular cells. T3, T4 is being made by the follicular cells, right? So yeah. Another abnormality is the branchial cleft cyst. Branchial cleft cyst is a remnant of the second, third, and fourth pharyngeal clefts. You remember in the beginning of this lesson, we discussed that that out of the 4 clefts that we have on the lateral surface, only the first one stays as your external auditory meatus. So second, third, and fourth should disappear. In some people, specifically the second or third, okay, that's more common, by the way. Second, third are more common. This one right here is fourth. It's very rare. Okay, this is a fourth cleft cyst. It's rare. Majority of the time it is second or third clefts. They persist. And if I have to kind of describe it to you, let's go here. So can you imagine that, you see that this is the second pharyngeal cleft? It should completely disappear, right? But what if all of this disappears, but this little tiny thing stays? It stays in the form of a cyst. It's filled with liquid of some sort. It doesn't cause any trouble, right? It doesn't cause anything. It's just, it looks weird, okay? So if you could argue it looks weird. It looks like a very weird mole of some sort on the neck, right? But this is just a cyst like that. Very rarely, the second pharyngeal cleft cyst does not stay as a cyst, but forms an opening, a little tiny hole here, little tiny hole. The rest of the cleft connects to the submandibular salivary gland. So when a person salivates, they don't only have saliva in their mouth, they also have it dripping on their neck here as well, the saliva. It's very rare when the second pharyngeal cleft actually stays as a cleft, okay? It stays as an opening right here, a little tiny opening. Think about it this way. If it is an opening, what does it think? It's like, okay, I'm probably an exocrine gland, so I should probably connect to something, right? So the closest to connect is the submandibular salivary gland. And as you know, this is the one that makes 75% of your saliva. It makes lots of saliva. So this is why sometimes these people will actually salivate from this hole downwards here. The solution is very easy. You just tape it with something and it will be fine. But of course you could look for the surgical closure, right? So just 1 or 2 stitches and fully cut down the actual connection to submandibular gland and it will be fine. But again, it's like so rare. It's like extremely rare. Majority of the time you see here a little tiny cyst or here a little tiny cyst, just a remnant of those clefts. This is for you, okay, when you're done studying. This is for you. What does each arch give you? What about the clefts? What about the pouches, right? So this is for you when you're done studying, just to go over it again. And this is about your nose. Very easy. Nasal cavity arises from the nasal pit. Do you remember? So this is a different picture. This is kind of like, I don't know, a cross section through your nasal placodes, right? This is one nasal placode here. This is another nasal placode there. There is a medial nasal prominence, which is somewhere here, and this is a lateral nasal prominence. So the same thing that we just saw, yeah, but from a different perspective. So medial nasal prominence, lateral one, medial, lateral one. What do we see later? We see that the 2 medial nasal prominences have fused together. When they fuse together, they create something which is known as the nasal septum. So at the deeper level, the fused medial nasal prominences provide you with a structure called nasal septum. What about the lateral nasal prominences? On their inner surface, you can see the concave and the meatuses. Okay, so the superior, middle, and the inferior concave and meatuses. How do they arise exactly? Nobody knows. So this topic is actually very good, because to talk about the nasal cavity, all you have to say is the nasal placodes, right? That how pit arises. Pit is responsible for the cavity itself. Fused medial nasal prominences are responsible for the nasal septum. The inner wall of the lateral nasal prominences provides this protrusion, the conchae, and the spaces between them called meatosis. So that's what you have to say, and it will be enough. We have to know something about sinuses. As you know, we have primary and secondary sinuses, right? Primary sinuses are something that you are born with, and secondary sinuses is the one that you get as you grow. A very weird question that they ask you is why the face of the newborn is smaller compared to a face of the adult. Sinuses. When you're adult, all of your sinuses have developed, and actually quite interestingly, they continue to grow. The older you get, the more sinuses expand. Babies, their sinuses haven't reached their final size. They simply just developed, and that's it. Okay, the primary sinuses. So yeah, okay, so sinuses, you have to remember that. What are sinuses? Diverticula, or outgrowths of the lateral nasal prominence wall. Okay, so just here and just grow this way and this way, and etc. Right? So the maxillary, the frontal, and etc. Some malformations, if you don't have a nose whatsoever, that means that there were no nasal placodes made. There was actually a case, I can't lie, but I think it's like about 4 or 5 years ago, or 3 years ago, like some kind of like this. A baby girl was born with no nose whatsoever. There's nothing here, nothing, just skin. I think it was in UK or US, and the government has offered the family to pay for the surgery, to make a nose. So you can do that. And the family politely declined the offer. They said that God has made her this way for a reason. So I think it's very interesting if the daughter will learn that she had an opportunity to actually make a nose, but her parents declined for it. I think there's going to be some kind of lawsuit coming up in the future from that family for sure. So basically she has difficulties with breathing, right? Because she's breathing through her mouth only, as there is no nose. The air is not moisturized properly. She's a bit more prone to infections, the respiratory infections as a result of it. So yeah, if you don't have a nose, you have no nasal placodes whatsoever. A single nostril, some people have just one opening. That means that you only had one nasal placode. And some people have a bifid nose, meaning that at the tip of their nose, there is a hole. There's some kind of hole. That's like a severe one. A less severe one is that you have a little tiny gap here. Okay, so like a little, some people have a very prominent gap at the tip of their nose, right? So that means that the two medial nasal prominences did not fuse properly. So when maxillary were expanding, they didn't expand properly, right? So you had a bifid nose as a result. And we're done for today. Okay, do you have any questions? In the group, I will send a picture of which topics we did, okay? So you can kind of highlight that part. And yeah, so I'm going to see you.
What are we going to do in the next session?
Tomorrow. Today, unfortunately, I don't know if you can hear the sound. It's been driving me crazy.
Oh, no. Okay.
This cup.
Yeah.
It's been like, it's actual torture in some cultures. Like I know in Russia, this is a torture in prison where they make this water dripping sound, but I can't reach that part. It's the snow melting. I wanted to do a double lesson today, but it's going to continue like this. Okay, so I'm going to see you tomorrow when the snow will melt, and we will discuss then if we can do a double class tomorrow. But
Okay.
for today, it will be enough. Yes.
That's fine.
Okay. Thank you so much, guys. Thank you for joining. I will send the video shortly. Thank
Thank you
you.
very much. Bye-bye.
Thank
very
you.
much.
Bye bye.